I'm going to talk about managing an asthma attack. Now, there's lots of different people within the room, so I know not everyone is clinical and may not entirely understand everything. So I've tried to make it as basic as I could. So the section in red is more clinical symptoms that the clinical people may want to look at. So these are the things that I'm going to be talking about. I'm going to be looking at asthma wheeze plans. And looking at mild to moderate, severe, life-threatening exacerbation, what we should be doing, when we should be considering prednisolone, a weaning plan, and follow-up plans after exacerbations. So first of all, we start off with management plans. This is advice that we should be giving to families and children, young people. So as part of North East London Asthma Working Group, we have decided that we would use Asthma UK and the monkey ones. There is also an adult one. I'm not using the adult one unless I have teenagers, because I'm trying not to get schools confused with having too many plans. So I'm using those two. They are now built on EMIS, and if you go to documents, and if you go on to Tower Hamlets, I can't actually read that. There's a working group committee section. It will actually tell you that you can download the actual management plans. They're pre-populated, so they're easy to use. It will then be saved on EMIS. The school nurse, the health visitors can see EMIS, I can see EMIS, and obviously the GPs can see EMIS as well. So that we're trying to standardise to use the same ones, because I've seen a lot of different ones used in primary care that are all saying the same thing but in different ways, which is more confusing for the family. We want to try and stick to these same ones. Having an asthma plan prevents exacerbation and hospital admission by fourfolds. We should be using them. We know that they prevent asthma deaths. They've got something to go back to, because often they might only have an exacerbation once or twice a year and they won't remember what they're supposed to do. And these plans will offer them that information to do that. So I've tried to break down the plan as easier to explain so that you can understand. So step one is normal. They're normal treatment. So their steroid inhaler, maybe taking their blue inhaler before they do exercise. And then we move down to the next step, which is number 2, which is when you start to become unwell. So their trigger is starting off an exacerbation. Most children's trigger is a cold. So they've started with a cold, they've started coughing, runny nose, then I would advocate for them to take their blue inhaler regularly at that time, because we know that that trigger is a cold. So when they're taking their blue inhaler regularly, I normally say they still do their normal steroid inhalers, and they also need to know when to seek a medical review. Now, when we say we use 10 puffs, we might use 10 puffs of a blue inhaler on a 16-year-old. Are we going to do the same on a 2-year-old? They get unwell very quickly and go downhill very quickly. So with the younger children, mainly like your 2 and your 3-year-old, or someone that gets sick very quickly, I say if they're having 5 puffs every 4 hours, they need to make an appointment with the GP. Sometimes families will say, I can't get an appointment with the GP, it's really difficult. If you tell the family to say the child's got wheeze, asthma, they need an emergency appointment, then the GPs will accommodate for that. But you have to be saying the right things. If you just say, I need an appointment for the child, and say, we'll see you in 1 week or 2 weeks' time. So trying to make sure that the families know what they should be asking for. The older children, if they're using their 10 puffs of their blue inhaler every 4 hours, that's when they need to be seeking for a medical review. And when we ask for them to be seeking medical review, it's to listen to their chest. How wheezy are they? Do they need to have steroid tablets to help with the inflammation? And I'll go on a bit more about that in a minute. Now, they also need to know what to do in an emergency situation. This could happen at school. Does school know how to deal with an emergency situation? So if someone is struggling to breathe and they're wheezy, they can't talk to you, they're panicking, then there's someone that's having an attack. Whether it's an asthma or wheeze attack, it will present in the same way. They need to take their blue inhaler, they need to use their spacer, they need to have 10 puffs, okay? When they're using their 10 puffs, if they get better, then that's great. They then go on to having their 10 puffs 4 hours. they go to the GP for the review for the steroid tablets. If they get no better, then you know that things aren't right. They can have another 10 puffs of their blue inhaler and call an ambulance, because most probably that they've got so much inflammation in their airways that they are just going to deteriorate, and we need the ambulance come in. Now, one of the things that we tend not to think about is allergies and asthma. If you have a child that's got food allergies or has an anaphylaxis, an EpiPen, sorry, not EpiPen, an auto-injector pen, then it's important that if they've had their burst therapy of their blue inhaler when they can't breathe, that they use that EpiPen. A lot of children from their post-mortems, if they've actually had an asthma attack, but they've actually died because of an anaphylaxis, because they're anaphylaxing in here that no one can see. A blue inhaler will help them, it will make them feel better. If it's not, then there's something that's wrong. It's more likely that it's anaphylaxis, and we must use your auto-injector pen. Yeah, and for that reason is one of the reasons why we're making schools have salbutamol for emergencies in schools, and also having auto-injector pens in school. We always say for them to have 2 auto-injector pens in case while you're waiting for an ambulance you need to repeat that. But the allergy team are going to talk about that later. Triggers. Most children that have wheeze and asthma just think, I have wheeze, I have asthma, not what causes it. There's always a trigger that makes those symptoms worse, and it's making sure that they identify which one it is and they know how to manage those symptoms. If your symptoms, your triggers is exercise, take your blue inhaler before you do exercise, so it opens your airways, you can run, you can do what you need to do. If they're needing their blue inhaler in the middle of exercise and afterwards, then their symptoms aren't controlled. They're most probably not taking their inhaled steroid, or their treatment needs to be increased. You've got things like cold weather, changing weather is also a trigger for some children. If it is their trigger, do their blue inhaler at that period of time for a couple of days when that changing weather. Making sure they've got the hat and the gloves, they're wrapped up and those sorts of things. We've spoke a lot about smoking, but that is a big trigger, and that we need to be making sure that the family's aware that their passive smoking is affecting their child. Mould. So at Hamlets we have lots of mould because of overcrowding. So it's important that we help those that are in really bad mould environments that have got quite severe asthma, that we do try and help that situation. We spoke about pollution. Food allergy obviously is a big thing. It's sometimes difficult for them to know what things they are allergic to, which is why we always make sure they have their auto-injector pen. But silly things, you can make a difference. I had one child that every Friday at school got wheezy, and when we worked it out, she actually was getting wheezy because it was fish day on Friday, and the cooking of the fish fumes was making her wheezy. So we got her to have her lunch somewhere else, so she wasn't exposed to those allergens. Cat and dog is also a big thing as a trigger. We have had a few children we've actually got rid of the cat, and it has changed and improved their symptoms, but persuading them to do that does take maybe a year or more before they actually do that, but it does make a difference. Dust mite allergies seem to be a big one, and I think Lou might talk a bit more about allergies, but making sure that they actually know what their triggers are, what's making their symptoms worse, taking their antihistamines when it's hay fever season and their nasal spray, not just when needed. So I just wanted to give a little patient scenario. So there's an 8-year-old boy who's got atopic asthma. He's got allergies. His triggers are exercise and cold. He's using his blue inhaler just for walking, going to and from school, and with exercise. He's had 3 admissions in the last year, and he's had 4 courses of prednisolone, and he's on 1 puff of a brown inhaler. So this is giving you a classic example of a child whose symptoms aren't controlled. This is not symptoms that we want from an asthmatic. He presents in your GP surgery, struggling to breathe, he can't talk to you, okay? Some of the clinical signs that we might be seeing for those of you that are clinical is exhausted, confused, he can't talk, he's got a silent chest, low saturations. If this was to happen, then you would be classing this as an emergency, and you would be given 10 puffs of that blue inhaler with the spacer. Okay. Now, I found it hard sometimes to find a spacer in GP surgeries, if the child has got saturations below 92, we would use a nebulizer with oxygen. There's no point you using your nebulizer compressor with a machine, because the spacer and the nebulizer is equivalent in drug dosage, but it's quicker, more effective with the spacer, less likely to give them infections from the actual nebulizer machine. So we always go for using with oxygen. And I don't know if every practice has oxygen facilities to be able to do that. One cylinder won't last very long when you're doing that. If you don't have those facilities, you're doing your 10 puffs of your blue inhaler, you're calling 999. They're coming to you anyway. If they're not improving, you will give them another 10 puffs while you're waiting for that ambulance. And by the time they get hit, they would have the oxygen and would be able to take over and help with the child. Now, with nebulizers, we also do say that you can have add in Atrovent, but I don't know if that's something that's regularly stocked in. That's just normally an emergency, which we tend to do in hospital. Yeah. So if he was to present to you with a mild to moderate symptoms, he can talk to you, but he might be working a bit harder. His breathing is working a bit harder. You might see some tugging on his shoulders, or he might be a bit quieter than normal. Mum's been following the management plan for a change and is giving him 10 puffs of his blue inhaler every 4 hours. So he's not doing too bad. He's okay. You don't need to call an ambulance. It's not an emergency, but we need a plan of what we're going to do from now. Okay. So we want to continue on 10 puffs every 4 hours. Now, there has been some question about using blue inhaler regularly and weaning plans. Are we masking symptoms? One of the problems that I find within Tower Hamlets is it's difficult with the language barrier to say to family, just give when needed, when you think they need it, because if you did that, they wouldn't give it. So having a guideline and a plan helps them to actually treat and manage the child. I would be given a course of prednisolone, which is extra steroids to calm the inflammation down so their blue inhaler can get in and work and help them. I would also be given a weaning plan, and I'd be making sure that I'd be offering a 48-hour review so that I can review them, check they're getting better. We know that when people have attacks, they're more likely to have another asthma attack or an admission within that month of that episode. So it's important that we need to keep an eye, and Chin's going to talk a bit about 48-hour review later. I would check his spacer. Has he got the right one? Is he using it correctly? It's a good opportunity to check what they're doing. Are they complying? Is he actually taking his brown inhaler morning and evening, or has he decided that he's fine, he doesn't need it anymore? So maybe there needs to be some education. He also has hay fever. Has he got allergic rhinitis? Is that causing the problem that's making his symptoms worse and we're not treating it? Do we need to give a nasal spray? Are they taking any antihistamines? If he was complying with his brown inhaler, then I would be increasing his management and stepping that up. Be referring to me so that I can sit down and go through some things because he meets my criteria. I would review in 6 to 8 weeks because I've increased his brown inhaler. If you've referred to me, then I can review that, which I've done a few times when you've changed some treatment. If we don't follow them up, then I find that they stop doing it, or things don't quite go right. You need to keep going and be positive, looking at the symptoms, doing the ACT so they can see, oh yeah, I am better, and that gives them motivation to carry on. If you was to review and their symptoms still were right, I'd be considering doing Montelukast or starting them on some purple inhaler. And then further review, if they're still no better, then that's when I'd be referring to secondary care, because maybe it's not asthma. When you have asthma, your treatments, you're normally controlled by inhaled steroids, the brown or the purple one. If it's not working, then is there something else? So this is another scenario. This is a 2-year-old who's had 3 admissions to hospital, viral wheeze. Viral wheeze, we always get, is it asthma, is it not asthma? And Chin's going to talk a bit more about that. It's the same management. They're both wheezing with colds, whether they have asthma or whether it's just a viral symptom, then they have no symptoms the rest of the year. He doesn't have any family history of allergy or eczema. Salbutamol works, it stops him from being wheezy, and he's had prednisolone once before, which worked. So I haven't done the life-threatening one because it'd be the same. We'd do the same management for whatever age. Now, Mum's been following her management plan as we're giving him 5 puffs every 4 hours and thinks, he's all right, but he's not getting better. I'm going to come to the GP surgery. If you was to review him and he was fine, he was happy playing, you've listened to his chest and it's been 4 hours since the blue inhaler and he doesn't sound too bad, then you would allow them to carry on following a weaning plan, which I'll show you. If it's been 4 hours post the blue inhaler and he's really wheezy and you can see he's working quite hard, then I would increase to them to give 10 puffs every 4 hours, and I would be considering if he needed to have prednisolone. You don't normally need to give prednisolone for the small viral wheezers. They will get better with the salbutamol and can follow a weaning plan, but there's a small proportion that don't. So you need to weigh up their symptoms, how unwell they are, and make a clinical decision if you think that prednisolone would work or not. Also taking into account family history, if there's allergies in the past. He's had prednisolone before, which was effective, and we know he's had hospital admissions. So I would be giving him some prednisolone, but I'd be starting a brown inhaler. He's had admissions. Obviously, every time he gets a cold, he can't cope. His airways are always inflamed, and that can be for many different reasons. So I would be starting him on a brown inhaler, referring him to my clinic because he's had the admissions, and I would be going through all of the education to check that they are doing things right, they know how to use their inhalers, when to seek medical help, they know how to use their wheezy plan, and I would be making them come back for a 48-hour review so that I could reassess the situation, check they're getting better, and they don't need to have more courses of the steroids. Is everyone following? So I also would be reviewing in 6 to 8 weeks so I can check the brown inhaler's working, it's improving his symptoms. I would also be repeating the ACT so that they can help the family identify and see the difference of the brown inhaler, and most of the time that's down to cough. You might find a lot of the wheezers cough all the time, and as soon as they're on the brown inhaler they've stopped coughing, so that helps doing the ACT. Making sure, checking they know how to use their asthma plan. If they came back and there was no improvements, they were still having episodes of coughing and more wheezy episodes, then I would be considering adding in some Montelukast. I would then think about making sure that we wean stuff down, because these children grow out of it. They don't wheeze all year round, and often we just leave them on their Clenil for long periods of time and don't reassess. The whole point of your reviews, and I know that we're going to start looking at these smaller children and reviewing those, is what are their symptoms like? Are they using their blue inhaler? Do we need to step down on treatment? And when you're stepping down, review them so that you can see, okay, yes, your symptoms are fine, we can continue going down, because I think a lot of that's not happening. And obviously, if there is no improvement, you need to step up. So your next step up would be a referral on, have they got something else? I always use the airways when I explain to families, because when you say to them, blue, brown one, what do? They can roll it off and tell you. But when I say to them, how does that actually help your lungs? They're like, I don't know. So I use my airways, and I always say to them, this here is a normal airway. This is what we want to aim for. Our second airway is an inflamed airway because of our triggers, and I name what trigger is for that individual child and say, okay, your trigger is hay fever. So your airways are nice and inflamed because of the hay fever at the moment. And then what happens is, this is when you're having an asthma attack. Your airways are narrow, inflamed, and that's why you find it difficult to breathe. You take your blue inhaler, it opens it up again so that you can breathe. But if you've got inflamed airways all the time, you have attacks, admissions, exercise problems with wheeze all the time because this inflammation is here on a daily basis. So they take their steroid inhaler, their brown one, to calm the inflammation down, to make it like that. So that prevents them from having attacks, prevents them from coming to hospital and keeps them well. Also check in that they're not forgetting, going through compliance, because a lot of them do not feel that their steroid inhaler works. What is the point of me taking it? It does nothing. And sometimes it takes quite a long time to actually get them to understand why they need to be taking it. And I do use the word deaf. Children do die, mainly because they're not complying taking their steroid inhalers. So you get the feel of what children, how far you need to pull it, but some of the teenagers, you really need to be open and honest with them of what they're doing to themselves. I get them to set timers on their phone. I've got sticker charts, get them to come back and look at your ACTs, have things improved because they're actually doing it every day, and getting them to actually realise that yes, that's them doing it regularly means that they're better. When we look at the spacers, there are lots of different spacers on the market that we can use, and currently at the moment, I've already told you, no one under the age of 5 should be using a face mask. We know that the mouthpieces are cheaper, so we can, if we give the correct device, it can be more effective. These volumatics are non-static, so before you use it, you should be washing it with hot soapy water, which nobody does. We don't do it in hospital because no one's got time to wash things before they use it. So sometimes it's, do we actually know how much we're actually administering because of the staticness? So Aerochamber have brought out new ones, which are the FlowView ones, which are anti-static free. They're a bit more child friendly. So they're ready to use. You don't need to worry about the staticness straight away. One of the issues that we're finding with the prescriptions is that when you look at the adult mouthpiece one, it says adult. So like anyone, why am I prescribing something that says adult if you're giving something to a child? These ones with the mask actually say child with masks. So everyone's prescribing the child because the alternative they've got is adult. Yeah. So with the new anti-static ones, we have now got an under 5 and we've got a youth, which takes us to 16, and then you've got an adult. But the only way it will show up on your prescriptions is if everyone keeps prescribing it, because the popularity of the prescription comes up at the top eventually. So when I'm asking to prescribe, I'm actually asking for the new static 3 ones because it says on there junior 5+. I'm hoping that makes it less confusing for GPs. With these ones here, it's got a different valve to the adult mouthpiece one. So it's less claustrophobic, it's easier for the family to use. Well, the child to use, because they're not having to breathe in tidal volume so hard with the blue ones. So a lot of them much prefer using these than the adult type ones. But obviously if you've got a strap-in big 15-year-old, then you can use tidal volume breathing in children. We always need to make sure that we shake the device before we give it. If we don't, then the medication is not distributed properly. So we shake between each one. And we do 5 to 10 breaths. Now it depends on what child, how much. I like using 10 because if you're having an asthma attack and you're hyperventilating and you're panicking, that will help you calm down. Some children will get bored and only want to do 5. So as long as they're doing 5 to 10, then that's fine. We always need to make sure we take off and we shake in between each one. Now, it's the same principles for all of the other spacers. We just need to make sure that we are prescribing the correct one for the child, depending on age. Yeah? I'm going the wrong way. Washing a spacer. Does anyone tell someone how to wash a spacer? Yeah, so we need to make sure that they look after their equipment. We need a new one every year, and we need to be washing it weekly or at the end of an exacerbation, depending on how often. If they're using their brown inhaler, they should wash it every week. But if it is just with cold, then they wash it at the end of that cold period. With the air chambers, you hot soapy water, and it comes apart, and then you just leave to dry. They should never be rubbing or scrubbing or doing anything on the inside. They just leave it to dry. Yeah, and then you can see with the large volumatic, that's what you do. There's lots of different types of inhaler devices. They're only good if you tell them how to use it properly. And we shouldn't be using it in children under the age of 8. So these ones here are AccuHalers. We don't use these in anybody in children unless you had a teenager that refused to take anything else. A lot of children that have difficult asthma find it really hard to breathe through this. So it's important that we use a volumatic and use a spacer one when they're doing their inhaled steroids. And we've had some children where their inhalers have been changed to this and they've actually died because they weren't actually inhaling the medication properly. And then you've got your turbohalers, which is also difficult, especially if you've got very severe asthma. So we tend not to use them too much. You've got your Easy Breathe and your Autohaler, which can be used pre-exercise. So if you've got a teenager that won't get their spacer out in the middle of playtime, they can take 2 to 6 puffs before they do their exercise, but they need to know how to use it properly. You need to demonstrate to them how to use it. And in an asthma attack, this is not enough. They need their spacer and they need their MDI. So this is not or, it's and. It's a second, another inhaler that you're adding on. Yeah. This here looks at all the different air chamber ones that you can see how they go up, and different ages is what it might come up on the prescription. So we will try and work to make it a bit easier when you're prescribing in primary care to help with that point of view, so that we are getting the static ones and we're getting the right age ones. But this is the one that I've been going for using at the moment. Yeah. What do we do after an asthma attack? So we keep saying the same thing. We keep them on 10 puffs every 4 hours. As they get better, on the second day we go to 10 puffs every 6 hours, then 10 puffs every 8 hours, then twice a day, and then when needed. So with a cold or a trigger, you're going to go up on your blue one and you're going to come down on your blue one. Try and stay to the same thing. If we start weaning down the doses, it confuses them. So if the hospital says the same thing and we say the same thing in school, it's less confusing for them. So this is the weaning plan that we're currently using at the moment. Unfortunately, there isn't a weaning plan on Asthma UK's management plan like there is on Monkey, so that makes it a bit harder. So we have got a book here that I always give out in clinic. Yeah. Any questions on that?
You're going to get all the slides.
Yeah, we'll send them out to you. So the last thing is the ACT. If you're using EMIS, I showed you where the EMIS templates of the management plan. There's also a section there for 48-hour review and for my consultations that I do, and it has actually got the ACT electronically and it will record it for you. You can use the templates that I use as well if it's helpful, and that's basically just to look at the different questions to ask a family as an objective measure of what their symptoms are like before and after you've seen them.